So it's my pleasure now to introduce to you the case that we have selected for the IVUS guided robotic PCI. It's an 83-year-old male patient who presented with stable angina class 3 according to the Canadian Cardiovascular Society with a positive nuclear stress test and a large ischemic area infralateral. At the time of presentation, patient was troponin negative, so no acute coronary syndrome. He has a profound cardiovascular risk profile, including arterial hypertension, hypercholesterolemia, and he's an ex-smoker. In 2014, the patient received a recanalization of an RCA CTO with 5 drug-eluting stents. When we did the coronary angiography, we found a mid-left circumflex stenosis with 2 side branches originating proximal and distal to that. And you see on the right coronary angiography that there's this full metal jacketed with the 5DS within that vessel, but not stenotic. So the target clearly is the mid left circumflex artery stenosis. So our strategy for the robotic PCI will be to use the Robotic to wire the main branch of that circumflex artery, do an IVUS co-registration, followed by wiring the side branches, again using the robot. Then we're going to plan the lesion preparation according to what we see on the IVUS, followed by stent implantation, IVUS control, and if necessary, post-dilatation. Now you're sitting me here in the control room of our cath lab where we plan to do the robotic PCI. Actually, you see that I don't wear a protection lead coat any longer. It's not necessary when I'm sitting here. And now it's my pleasure to present to you my workspace here. So you see that I don't have direct visual contact to the cath lab inside, so we install the camera that allows me to see what is happening in the cath lab. I have audio control with the nurse and the fellow inside the lab in order to proceed and to do the things over there. The real workstation of the robot is here. I have a console which allows me to manipulate the robot. Basically, it has 2 joysticks on the right side. This is the joystick for the wire manipulation. With this joystick, I can advance the wire, I can retract the wire, and I can torque the wire in both directions. I can do that slowly, I can do that faster, and I can do that turbo by pushing the bottom on top and advance or retract. In order to do that, I need to activate the joystick by pressing the bottom behind. On the left side, there is another joystick. This joystick is for advancing balloons, catheters, etc. Basically, you can again advance the balloons, catheters, you can retract them. You can do that slowly, you can do that very fast, and you can do that turbo way by pressing the bottom on top of it. Now the new console has the additional option to have a millimeter stepwise advancement or retraction of the balloon. In front of me is now the monitor. The monitor covers the same parts as we do have inside the lab. I have the opportunity to have different setups to be chosen with different imaging modalities, which case-oriented I can select even during the procedure. So no difference whether I'm inside the lab or outside, I exactly see the same. And of course, what I need to do is I need to expose the X-ray from here. So I do have a foot panel in front of me that allows to both have fluoro as well as cine from the table here. And then most important, I have the opportunity to also make contrast injection via a hand contrast injector that uses an automatic injection within the lab. So I can do that from outside, from here. And finally, I have additional mouse that allows me within my monitor to work with different additional conformities, options like IVUS, etc. You see the wire at the end of the guiding catheter. Now it goes better. And then we manipulate it down. So you can see I already went down for the first side branch just to show you. briefly. Yes, we are in there, but I don't want to go in with the first wire there. I want to go to the main vessel there because I want to do the IVUS pullback with co-registration first. So I retract a little bit and then move again. You see, while I'm doing that, Diana and Milad are standing behind a protection shield, so they are far away from X-ray exposure while staying in the lab there. And try to go to the main vessel, which is right now here, the case. So this is great. So I want to just show that and film that briefly, that we are in the main vessel. That's great. So you see that I advance it, goes straight through the lesion. And now I'm more or less distal to that. Good. And now the pullback is going to happen very slowly. You can see that the wire is nicely fixed in there. And now I'm back in my, we can stop the recording. So distally, we are in the range of about 3.0. Proximally, we are in the range 3.5 to almost 4 by IVUS. So I think we're going to need to position something like a 3.0 distally that then goes up to 3.5 post dilatation there. So I try to bend it that it looks into the circumflex artery. Yeah, it looks to the LAD. Yeah, now it looks down there, and I try to advance it slowly, and then let's see whether we can get it in one of the side branches there. So now it goes in the main branch. Try to manipulate it and try to bring it down to that second side branch. Now we need the third wire. I gently go in there. There it goes. And here we are directly into that side branch there. So now I will advance my balloon down to the lesion. Here it comes, and I try to go there, and I think that's a good spot to start with. Okay, now I make an angio, and this is what we achieved with our balloon, which is not too much. So I think we have to make a better lesion preparation before going there with the stent. So a quite rigid kind of lesion with a lot of recoil. So I will now advance the scoring balloon in order to bring it to that position. This is 15 millimeter long, 3.0 scoring. We did pre-dilate that lesion, so I think that was a 3.0 balloon. We still have some recoil, so we have to be careful with our side branch wires that they stay in place during the change maneuver. Then I advance the stent, which is at the end of the guiding catheter. It goes in now. Yeah. And now I can, on a millimeter basis, exactly position the balloon. So I will just gently give a puff. So this is actually quite fine. I will see that. Yeah. Andrographically, the side branches are open. This is important. But according to our measurements, I think we have to upgrade the size of the stent, in particular in the mid part and the proximal portion. So I will now advance the post-dilatation balloon. And we're going to see where we have to go a little bit further, a little bit further. So here. It looks pretty nice. We have some impingement of the first side branch there, but the flow is good. So as I mentioned initially, I will not do anything on that. So angiographically, it looks quite okay. So we're going to now control and repeat our IVUS co-registration. So I think it would be good to post-dilate with a larger balloon here in order to increase the lumen. You see, it slips in there. Should be not an issue, really. Then let's see where we are. Yeah, that's not too bad. So I think we can start here. And now you can see that we have significantly increased the lumen that we have achieved. Now, I think that we have achieved a fairly large lumen using a large 4.5 millimeter balloon that really opened the lumen much more. When I look at the stented segment here, there is no longer a large plug burden outside of the stent. So I think this is acceptably fine. So I think we have achieved a fairly good large lumen there. Both side branches are completely preserved. And I think this was a very nice example of a robotic PCI in a case with, if you want, two bifurcation lesions, one at the proximal end and one at the distal end, and we attempted a single device strategy. I was guided. I think it was very important to see the dimensions in order to achieve an adequate lumen. We need to use large balloons here at the end. With respect to the robotic appearance and usage here, it was important to appreciate that we worked here with three different wires, one working wire in the main vessel and two side branch wires, proximal and distal, all manipulated by the robot. They were easily to steer, and it was really easy to bring them down there. Honestly speaking, I wouldn't have expected that to be as easy as it appeared to be. Now, having said that, I think we are done with that case. I want to thank the whole team here for collaborating in this important presentation, and therefore we're going to finish right now. Thank you.